James Salwitz, who's a medical oncologist with the Regional Cancer Care Associates Group. And as he said earlier, while we have a formal presentation here, the intention is really to respond to the concerns and questions that you have without it being an individual consultation one-on-one with the doctor, but more so he can answer your questions and try to make it useful and relevant to the whole audience. Sound good? Okay, Dr. Salwitz, you're on. Thank you.
So we are here this morning to talk about a disease that affects each one of our bodies and our families. But given what's happened in the last week in France, I thought it might be appropriate to take a moment to remember that there is another cancer, and that is the cancer of international terrorism. And that is a disease which is sadly growing, metastasizing, and threatens again each of us, our families, and this time even our societies itself. So I just wanted to take a moment to maybe a moment of thought, maybe a moment of prayer, for obviously for the lives that were lost, the people that suffered in Paris this last weekend, but also hope for our leaders and those that will put themselves in harm's way to try to eradicate this disease. So I just wanted to take a moment. Thank you. So in 1980, 75% of patients who got the diagnosis of cancer died of their disease. That number has been cut by almost half. There will be soon over 20 million cancer survivors living in the United States. The change in technology, the treatments, the opportunity has just been incredibly revolutionary. You know, we are definitely winning the war on cancer. It's piece by piece, it's moment by moment, it is an ongoing battle, but we live in an incredibly exciting and powerful time. And this is the explosion in new treatments is just phenomenal. The new technology and understanding of genetics and immunology and the disease and how it spreads is just incredible. And this is, interestingly enough, resulted in a problem. This, I guess, is a good problem to have, but it clearly is a problem. And on my side of the fence, when we go to conferences, we call it survivorship, which is to say, what in the world do we do with all these people that are now surviving? You know, on your side of the fence, you call it side effects, which is probably a much more reasonable thing, but doctors, we like to embellish everything, and it's hard to publish something that says side effects when you say survivorship 101. But this is actually a major theme, more and more, of our conferences, you know, of discussions of the literature, and that is, how are we going to deal with the fact that now people, even if they have cancers we can't get rid of, live years and years and years. I mean, you have to remember, when I went into practice, I left the NIH in 1987, the average survival of ovarian cancer was only about 6-7 years. Now, I have patients even that have recurrent and advanced ovarian cancer that I'm looking at not 5 or 6 months later, but I'm looking at 5 years later, 6 years later, and the survivals are incredible. But what that means is that patients live longer, do better with all these cancers, is that we have to be aware that they want to go on with their lives. They don't want to spend their entire lives in our office, and they certainly don't want to be handicapped by the side effects that have occurred. So survivorship and side effects have really risen to the top of what we now think about more and more in organizing a therapy. You know, once upon a time, if I use the ovarian cancer side effect again, you know, we had basically one drug to treat ovarian cancer, and we had to deal with its side effects. But since a patient might only survive less than a year, you know, you kind of balance that out against that short time. But now if the patient is going to live 3, 4, 5, 10 years, they're not going to be very happy if they can no longer feel their feet, you know, or they're short of breath all the time, or they're in pain all the time. We have to more and more say, what do we have to do to let people live their lives? We don't really want cancer patients to become the classic cancer patient. which is someone frail and weak and in pain in some corner somewhere, just kind of waiting to what's going to happen the rest of their lives. We want people to be out and living. And there's two reasons that we want that to be. One, it just makes good common sense that people really want to live their lives and feel well. But secondly, we have better and better data says that patients that are like that, people that are out and moving and eating and living in society, live longer, live better. They're less likely to die of their cancers. I mean, the data is remarkable that people that are mobile and exercise and involved are less likely to get blood clots, less likely to get pneumonias, but even remarkably, for several cancers now, we have data that is actually less likely for their cancers to come back. Now, we don't have a brilliant solution to that, why someone that's walking, half an hour 3 times a week may actually have less likelihood of dying of their colon cancer. I mean, we don't have a good explanation for that yet. But we have more and more data that says that if we can keep patients out and mobile in the community and involved and living their lives, they're not only going to be happier, they're not only going to be involved in their communities and doing what they really want to do, which is live, but they're also more likely to being cured, more likely to surviving longer. So survivorship side effects has become more and more of right at the top of our consciousness when we start to design therapies from the start. So that in reverse, therefore, must also be the goal of every patient and every family. Not only what is the chance that I'm going to be helped by this therapy, what is the chance I'm going to be cured, but also, what are the side effects? I mean, what does this look like a year from now, 5 years from now? What am I able to do and not do? Which I guess gets to the first part, of any cancer plan when you're thinking about that long-term picture and avoiding side effects, and that is the patient and the family are really the one that must be in control. This is not about the medical professional, the doctor, being in control. This is about the patient and the family deciding what is right for them. The physician is a guide. The physician hopefully sees you as a friend and someone they want to take care of, and the physicians generally are highly motivated to do the very best they can for each individual patient, but each individual patient has to decide the path that they're going to follow, because you're not going to follow a path that's completely wrong in your mind, and the physician's going to design something that just doesn't work. So we start with, when you start thinking about survivorship, when you start thinking about side effects, what will an individual patient and family, what feels right to them, what can they deal with, how can they handle it, what is the right therapy? And in the end, there is only one right path, and that's what the patient says. So we start this conversation by saying, you have to be in control. You have to know what is going on. Now, there's a level to that. So if I'm taking care of, a 20-year-old, who's super computer savvy and just took a molecular biology class, yeah, he's probably interested in the actual genetics of his cancer. Great. That's that, And if I'm taking care of my dad, who's 91 years old and has prostate cancer, et cetera, he is not interested in the genetics. He's not interested in the names of the drugs, if he can remember them, et cetera. He's interested in only one thing: can he get out, and play his poker game 2 times a week. So for him, the rest of it is it's the blue pill on Tuesday, and that's enough control. And for everyone else, every patient, that's the point. You have to figure what is the information that you're right. But remember, every patient, remember that it is not the doctor, the nurse, the medical system's job to tell you what is appropriate. It is your job to be educated and learn and be in control. And as a side piece of advice, if you find yourself in medical relationships where you don't think that's happening, not being listened to by one of my colleagues, maybe me, by a doctor, is not a minor thing. And that's not just somebody that's being a little bit rude or is not listened to. That's a problem for your medical care, because it means the medical care might go someplace that just won't work for you. Now, a side piece of that, the next thing is then communication. If there's a critical need for you to know and how to communicate and connect to your physician and to your medical team. You should always know when your next appointment is. Every now and then I have a patient, who leaves the office, et cetera, and then my computer pops up something a week or two later. I said, why aren't they not back yet? And they had left the office. I say, oh, we didn't have an appointment. You should never not have an appointment. You should always know the next moment. You should always know how to get a hold of your medical caregivers. And if there's a problem, you have to fix that. Now, I'm a big fan of cell phones. My card that I give to every patient has my cell phone on it, because contrary to popular opinion, I find patients do not abuse cell phones. They only call me when it's really, really, really necessary. I do have one patient that calls me about her knitting about every 3 weeks or so. Okay, I can deal with that. I deal with that. But the vast majority of times someone calls me, they call me and say, listen, there's a problem with my medication, or I can't get through it, or I'm having a fever. So I happen to believe in cell phones, and I happen to believe in email, et cetera. But that's just a technique. You should know what your technique is to connect to your caregivers and how you're going to find their time and how they're going to get information from them, because you can't have a relationship if you can't be in control, if you can't get other people there. And these are, this is not a side thing. This is the core part of being in control, which is a side, core part of, getting on with your life. And I do think, whenever possible, the more family support you have, the more people in the room when you go see the doctor, the better it is. If I'm seeing a patient who's going through a difficult time and I walk in the room and that patient is by themselves, I have a heart attack. That's a bad thing for me, because this is not going to go well. Because the first thing I'm going to say is, well, this is the problem, and that's the last thing that patient heard. So whenever possible, I'd love friends or family members or other people in the room. When I walk into the room and there are 11 people in the room, hey, I'm thrilled. Because we're all going to hear the same thing. I'm going to hear what they need. Everybody's going to work back. But again, it's building this communication base. It's being in control. It is extremely important. I am a big fan of the internet as a source of information. I'm not necessarily a big fan of the internet as a source of accurate individual information. So the internet's very important for patients and families because it begins the conversation. But then you take that information, to your caregivers and say, how does this fit with what you're telling me, and take that with a grain of salt until it's, put into the kind of context. So this kind of information, this kind of interaction, you being in control, is critical to you maintaining the highest functional status in your life, which has to do with getting the best care, which has the best chance of living long, living well, and beating, this often awful disease. All right, so what are the common side effects that we see in treating cancer? I mean, other than the bill, we're going to ignore that for the moment. The most common side effect we have the most trouble controlling is fatigue. Is that you feel tired. And you feel tired within cancer care for a large number of different reasons. You feel tired perhaps from the cancer itself, which can drain someone. You feel tired because of tests, and if you're getting a colonoscopy followed by a CAT scan followed by other tests, etc., this is just tiring. I mean, for any of us, the prep for these tests can be exhausting. You feel tired because you may be anemic, meaning your red blood count may be low. You may feel tired because of chemotherapy agents or other drugs which can drain you. You feel tired because you're not able to function and exercise and do as much. And this is, and fatigue is a gigantic problem for us. It's actually at the top of most people's list of the things that is hardest to handle. And fatigue is a problem because if you're not active again, you may tend to get weaker. Every day you stay in bed, you get a little bit weaker. Maybe a wound may heal a little bit, but you lose a little bit of energy. So fatigue is a big problem for all of us, in treating this disease. So first thought is you need to be aware that this is an issue. Second thing in handling fatigue, you have to be aware that you want to fight this. Like I said, if you're tired one day and you get into bed and you don't really need to be in bed, you may be even a little bit more tired the next day. And you all have to work to be out and to move and to try to do more. The more you're able to exercise, the more you're able to get out of the house, the more you get out of bed, the more you're able to move around, the less likely you are to get complications or side effects, pneumonias, but also the less likely you are, to be fatigued. You want to communicate this side effect to your caregivers. So the caregiver may say that you're moderately anemic, et cetera, and say, it's not a big deal. But you're going, holy geez, I can't get out and go shopping, so I'm really tired. And if you don't say to the caregiver, listen, I'm really tired, because then maybe something they can do about the anemia, in that situation, or by another blood count or something else, that can change. We don't have great medications that directly handle fatigue, but sometimes some basic things that you can do, can help. There's a real tendency with treatment of cancer for people to get dehydrated. And if and you get dehydrated because maybe you're nauseous. You get dehydrated because you're just kind of laying in bed, you're not getting out, you're not eating as much. You get dehydrated because a lot of the drugs and treatments we use actually drain fluids, et cetera. So if you get chemotherapy, the day, maybe 4 glasses of fluid was good the day before chemotherapy, but on the day of chemotherapy, you may need 8 glasses of fluid just to flush the stuff out of your system. And as we get dehydrated just a little bit, what we happen to do is we tend to get tired, and then we drink a little bit less, and then we sit around because we don't drink less, and it gets worse and worse. So you can handle that yourself by just being aware. I need to make sure that I'm drinking excessive amount of fluids during this time of treatment. I need to be aware of my tendency to become dry. And by fluids, I'm talking about anything which we would call clear liquid. Water, juice, Gatorade, soda, sherbet, Jello, soups, an occasional beer. These are fluids just to flush this stuff out of your system, and it's very important to stay on top of it because that is a major cause of fatigue, as well as making it harder to treat you in general. It's also important with fatigue that sometimes you do need rest, and one of the things, unfortunately, that a lot of our therapies do tend to interfere with is sleep. And we all know how precious sleep is. And not getting sleep makes us tired, but it also makes it very hard for us to cope. It can make us put on stress, anxiety, and sleep itself can become a problem, which adds to this. And sleep is something you want to talk to your doctor and say, listen, I'm just not sleeping. So there was a patient in the office this morning, who commented to me that she had not been sleeping. And for the last 10 days, she just couldn't sleep anymore. So what did I start her on a week and a half ago? I'd put her on a steroid. Well, steroids are the gas pedals of the body. All right, that's what gets everything going. Well, if you take a steroid in the evening before you think you're going to go to sleep, you're probably not going to sleep very well. She told me what was happening. We were able to change the steroid around. Basically, the simple and obvious thing: take it in the morning. So hopefully, she can sleep a little bit. So you need to know. Your doctors know that if you're not sleeping, you need to practice good sleep hygiene, is what the experts say. I never particularly like that term, but that's what they call good sleep hygiene, which means there's only one thing, maybe two things, but only one thing basically that you do in bed, and that's sleep. We don't read in bed, we don't watch TV in bed, and we don't lie in bed awake either. So the experts in this area say that if you're in bed and the lights are out and you're not asleep in 20 minutes, get up. You're not going to sleep, you're not going to sleep. But don't teach your body to be awake in bed, because that is a pattern that your body kind of learns. There's more and more data that says you need a computer screen within an hour before bed because of the type of radiation we receive from the computer screen may interfere with REM sleep. So that may also something be added. And also let your doctors know. Physicians can give you medication for sleep. Physicians tend to hesitate a little bit sometimes on sleep medications because they have their own set of side effects, which is, say, if they don't wear off great for the next day, or even more tired. But let your doctors know about sleep because, again, that's a way of handling fatigue. And that is part of being active and out. And again, that's part of it. You want to be active, you want to be moving, you want to be involved. You don't want to be sitting in a corner if at all possible, because the more you're able to do, the stronger you are, the better you're going to feel. Every patient I've ever met, when I talked about cancer therapy, has been concerned about nausea and vomiting. Now, the reality is we're really good nowadays at preventing and treating nausea and vomiting. Once upon a time, when we had only 10 chemotherapy agents, we had almost no anti-nausea medications. I remember having to bring patients in the hospital just to give them chemotherapy because I knew they would be sick for 2 or 3 days. Almost nobody has to do that anymore, and our anti-nausea medications are really, really good. Nausea is something that's treated with prevention as much as possible. So your physicians are aware, but you should be involved with this, that you should be receiving anti-nausea medicines before treatment, and then with treatment, and then you should have something already at home to take in case you're nauseous. And in case it's not working, again, reach out to your caregivers. We have the physicians, the nurses, who's ever taken care, and let them know. There's nothing gained by being nauseous. The cancer therapy doesn't work better if you're sick. You're not supposed to be. And if you train your body to be nauseous after chemotherapy, then it just gets worse and worse. But we have really good anti-nausea medications, which can go a long way towards preventing this. And so this is just should not be a major problem for you in this therapy. And if it starts to be, let people know. We have lots of different choices of anti-nausea medications as far as that. On a sidebar, yes.
I'm on Gleevec, and I'm nauseous every day.
Okay?
After I take it.
Okay. So, yes. So the question was to take a medication, Gleevec, imatinib, which is used to treat certain chronic leukemias and certain tumors of the abdomen, just of the abdomen. This is a pill. You take it once a day, probably, and you're getting nausea. So first of all, it's interesting. That's an unusual side effect for Gleevec. It's not one of it's low on the anti-nausea, sort of scale. I mean, it's very critical that your physicians know you're going on. There are other choices of medicines that might be used instead. It can be a dose phenomenon, of that particular medicine, so it can be adjusted. And there are other, and I assume they've tried various anti-nausea medicines with you.
I've never taken anything.
Okay, so it's worth reaching out to your physician saying, what do you have, as far as anti-nausea medicine? Since Gleevec is a once-a-day medication, sometimes patients can take that with the anti-nausea medicine at the same time, to prevent it. Often we teach, particularly for one medicine that we know causes nausea, we teach our body to be nauseous around something. And once you've gotten that pattern, it's really hard to break. It's called the poison bait response. Actually, every animal does it. We teach our brain. And the way to do that, to break it, is to take a nausea medicine beforehand. And so but I would definitely let physicians know it's definitely something that's handleable. And particularly for a medicine that you have to take every day. For Gleevec's a medicine people may take for years. That's really awful. So you really want to, you're going to want to deal with that. Oh.
Is there ever any benefit to changing the time of day that it's taken? Does that have an impact in terms of what this lady is describing?
Right. So the question is, can you just play around with times of day? Absolutely. So, and that's true of many side effects. So if you're taking a medicine that makes you sleepy, like thalidomide, Revlimid, which are anti-myeloma therapies, we always tell people to take them at bedtime because they were originally marketed as sleeping medications. Bedtime. And anti-nausea, if it makes you nauseous, taking it at bedtime, can make a difference. Either taking it with food or not taking it with food, can make a difference. Taking it with other medications can make a difference. But that's something that's definitely handleable. And for a chronic medication, that's not a reasonable, thing to tolerate, and it's certainly not necessary, to tolerate. On the thinking though of chronic nausea. A thing that New Jersey now has, as many of you may now have, is medical marijuana. And medical marijuana has as one of its major benefits is nausea. So we have patients that have for severe chronic nausea for either treatment reasons or cancer reasons or other diseases. Medical marijuana has been a major benefit for these kind of patients, as it has had actually for multiple other medical conditions. But in the basic situation such as this, I would let your doctor know and say, let me try an anti-nausea medicine with it. Try the time, moving around time with food, etc. Look at dose. There's a bunch of things that can be done. It's not necessary. Another major side effect that patients, are always hesitant about with cancer therapy, is losing your hair. And there are many chemotherapy agents that unfortunately do make us, lose our hair. Chemotherapy attacks rapidly changing cells. The cells in the hair are among the most rapidly growing in the body. And actually, chemotherapy doesn't actually stop hair from growing. It actually just cuts it. It just cuts it for a day. Because most of these chemotherapy drugs are out of your system in 24 hours, most of the intravenous. So just for a day, it just cuts it. But it cuts it about a millimeter below the skin line, so after it's cut at one time, you don't ever see these little pieces again anymore, and so it cuts it. We don't have a brilliant solution to this problem. There's been a recent resurgence of cold caps, which people wear on their head with chemotherapy. Oncologists have always debated the idea of using cold caps because the way cold caps work is they cut down circulation to your scalp while you get into the chemotherapy. And oncologists always kind of get this nervous idea, if you're giving chemotherapy, don't you want it to go everywhere? So we don't have a brilliant solution to that. And the good news is that many of the newer drugs that we're moving towards, a lot of the new oral anti-cancer therapies don't do this by any means as much as it used to. But the best treatment is for hair loss. The best prevention is get a wig before your hair falls out. That's really important. If it's going to fall out, and your doctors are going to know it's going to fall out most of the time, go and get a wig and see and get that done, beforehand. That's really an important thing to do, just so you don't have to deal with that, that change in your life. That's one of the harder things that ever happens. And when someone tells you you have a scary disease, it tells you the therapy is really scary, and then just to underline it, you look in the mirror and suddenly you're a different person. And that's a really hard thing, so it's worth trying to prepare for that and prevent, that impact, when that occurs. With cancer therapy, we worry a lot about infection. These are drugs that have complicated effects on our entire body, but certainly on our bone marrows. And a lot of our drugs cause drops in bone marrow function for periods of time. They generally occur some few days after each chemotherapy treatment. The blood count drops, and they come back up. But there's a period of time with a lot of our drugs when our white blood counts, tend to be low. This is a time in which we are at some increased risk of infection. Now, first of all, we're able to prevent this a lot better than we used to. We have medications that stimulate bone marrow recovery so that the blood counts come back faster. It's not that the blood counts don't drop. They still drop, and they drop depending how low they drop for how long, depends on how severe the drug itself is, and how severe the treatment is. But they do have some, tendency to drop. So we use drugs like Neupogen and Neulasta, and Granix that stimulate bone marrow recovery. But there's still a time in which your blood counts drop. Now, again, there's mixed schools on how far you have to prevent this, and it depends on the patient and it depends on the treatment. A lot of oncologists, myself among them, worry less about the chance of catching something from somewhere else than they worry about someone going in the house and closing the door, not coming out when treatment. So we really want people out and around. We want people, seeing their families. We want them around their grandchildren. And there are certain times, if you're around people that are obviously snotty and drippy and sneezing, that's probably a good idea not to be giving them, nice hugs, et cetera, at that point. But it's important to be out and around, and most of the time that's possible. Your doctors will tell you, right now your blood counts are really low, your immune system is really frail, be a little more cautious. But most of the time, this is not an active issue. You can still be around people, and you should be around people, and you can generally, eat the things you want. And people say, well, don't eat anything green, don't eat anything fruit, don't eat anything fresh. Well, you might as well not eat it all. So I mean, and you worry again. I watch more about, not taking care of your body, not getting nutrition, than any risk of infection. And the other side is this: most of these infections you don't catch. Most of these infections come from somebody else. Don't come from somebody else, excuse me. They come from your own body. They come from your own mouth, your own teeth, your own gut. They're internal infections. And that's why a lot of times oncologists, when they first start chemotherapy, will say, how are your teeth? You need to see the dentist when's the last time they cleaning. Is there anything going on? Because they're worried about that. So, infection is really a concern, but it is the best way to prevent it a lot of time is by being active and being out and around. Now, you should have very clear instructions from your treating doctor about what to do if you think you might maybe getting an infection. What to do if you start getting a new fever, or start getting a new cough, who to call, when to call, how to get a hold of someone. And you shouldn't hesitate to reach out. We have Thanksgiving coming up next week, so every 4-day holiday, there's always someone on Monday morning who calls and says, I'd like to see the doctor. And you go, what? I've had a fever 103 for the last 3 days, and we're not, and they come in and they're just going, straight to the emergency room, do not pass go. If they'd called 4 days ago, we should have called in a prescription. So don't hesitate to reach out. Again, this is about connecting and letting people know, what's going on. So don't hesitate, to reach out so that people know. And don't. This is not a time to be tough. So I'm pretty much talking to the men, in the room out there. This is not a time to be, machismo. This is the time in your life to be whiny. We really appreciate whiny. We really do. People say, I don't want to bother the doctor. No, the doctor really wants to be bothered because he really would rather see you in the office or call in a prescription than see you in the emergency room or, forbid, the intensive care unit. So that's, oncology should be treated patients in the outpatient setting. We should avoid hospitals as much as possible. And the more whiny you are, the better you do. When you go to the doctor, show up with a list. Now, so my patients come in and they go like this, I can't, it says, you're going to be here for hours, I got the list. Well, most of the time, that doesn't take me hours, to go through the list. But if I have a list in front, I know we're not going to miss things. You know, because if the first thing they say is, you know, I have this spot on the arm, and I say, I think it's nothing, see the dermatologist, the rest of the visit, they're still thinking about the spot on their arm. You know, but if they have, listen, I have the spot on my arm, I had diarrhea last week, my mother-in-law's visiting, whatever, you know, whatever's on the list, you know, so we go through the list together. So lists are really important, just like having that other person there, et cetera, you know, and having that, you know, connection. Again, it's about reaching out and connecting so, you know, so that people know what's going on. A lot of the modern chemotherapy drugs we worry about, and this is a big problem for us when we talk about survivorship. Because this is something that can sneak up and cause real problems for patients that over the years, and that is neuropathies, and that is nerve damage. So there are a number of drugs that we use that have the potential to cause damage to the long nerves in our body by which we feel things. And the longest nerves in our body are the nerves that goes from our back to our feet. You know, think how long that nerve is. You know, or go to our arms. And you have these long stretches of nerves, these long wires, and that entire thing is exposed to chemotherapy agents. And a number of our drugs can cause potential nerve damage. And we're talking about the possibility of someone that is cured of cancer, and I know these patients, who permanently feels as if their hands and feet are burning. And you know, thinking you sleep on your hand in the middle of the night, you wake up, bzzz, well, think of that's happening all the time. So neuropathies for us make us really nervous because some of these neuropathies can take a long time to heal, and some of these don't heal at all. You have to remember the nerves heal like grass, how grass grows from one end to another. And for a nerve to heal from my back down to my foot, that takes a long time, given the nerves only heal like a millimeter at a week, you know, if they're blindingly fast. So we worry a lot about neuropathies, and with a lot of drugs that we talk to our patients about, and we're constantly asking, do you feel any numbness or tingling in your feet? Do you feel any numbness or tingling in your feet? And they think this is some sort of a foot fetish. But this is a critical, important question for us because the slightest symptom may be a hint that something is starting. And one of the problems is that some of these are delayed. So we're looking for slight changes frequently with a number of drugs. So particularly in the taxanes, or Taxotere, Taxol, the platinums, cisplatin, carboplatin, some of our other drugs, we're constantly asking about neuropathies, particularly because a number of these are used in curative regimens. People are going to be cured, and they live in their lives for years and years, and having nerve damage is the last thing we want to happen. We commonly use a drug called oxaliplatin now to treat people with early stage colon cancer, because if you give it to someone that's had colon cancer and the colon cancer has been removed and they look fine, but then you give them this chemotherapy, some patients, not all, but we're talking about basically stage 3 patients, you give them this drug, it decreases the chance they'll ever see colon cancer again. It's really cool. It's kind of preventing stuff. But the problem with oxaliplatin is it causes a neuropathy. So if I've taken a 38-year-old mommy with colon cancer and I've cured her, but now her feet burn and tingle and she has trouble walking the rest of her life, she's not appreciative of that. Obviously she's appreciative that she's cured of the colon cancer, but there's something there that I should have done my very best to prevent. So the point of that is be aware if the drugs that you are receiving or the treatments you're receiving can cause neuropathy. Be aware of these singlings, burnings and tinglings and stuff, and talk to your doctors. Now, we'll talk about this in a second, we'll talk about nutrition. There is some evidence that the better your nutrition during treatment, the less likelihood this is going to occur. But the most critical thing is, again, keeping your doctors aware, being aware of your body, and be whiny. Let people know, if these start to change. Yes?
What about shooting, piercing pain in your feet? That's new.
So the question is, what about shooting, piercing pain in your feet, which is new? So that is something that your doctors absolutely, definitely should know about. Now, there are several reasons for shooting, piercing pain. I mean, people who have diabetes have this as a common symptom. There are some other drugs that can cause it, but it can be a sign of something early, and doctors, need to know that kind of thing. Of course, it can be arthritis, et cetera, that is causing twitches and tingling. But yeah, it's important, those kind of questions, et cetera. I mean, I think your doctor needs to know about every discomfort, you're having. And again, your doctors want to hear this information because they don't want to deal with this information, deal with a complication that could have been prevented and made your life better. You made your life by helping you, it could have been better. So let's talk about pain. It's a good segue into that. So pain is a problem not just because it hurts. I mean, I'm not big into the hurting part either, but pain's a problem because it stops you from healing. So if you have pain, you don't get out of bed. So you get more tired. So you get your blood clots, your pneumonia, your fatigue. If you have pain, you don't really have time to prepare dinner, you don't have time to eat, so you don't eat. If you have pain, you get depressed. And if you get depressed, you don't get out of the house, you don't interact with people, you don't interact, etc. And you don't show up for your treatment on time, you don't take your medication. If you have pain and it's in your chest or somewhere, you don't take deep breaths and you don't move. If you have pain in your feet, you don't walk. And if you don't walk, you lose strength, etc. Pain is bad for you. And the point about this is that patients say to me all the time, I'm having pain, but I can take it. No, you can't. I can take it means that, for a man it means he sits there in front of the football game, but he's not taking anything, etc. And for a woman it means she's going off somewhere, and it's not communicating. I can take it means I don't take my medicines, I don't get out, I don't socialize, I don't see my grandchildren. That's what I can take it means. Pain is bad for you, and pain needs to be treated, and we're really good at treating pain if we know what is going on. Now, as a side statement, this state and the United States in general, have a major effort right now to decrease the risk of narcotic overdoses in this country. 6,500 people in the United States last year died of heroin overdoses, 18,000 of prescription narcotics. Okay, so prescription narcotic addiction and overdose is a major problem in this country, and we need to deal with it. But we're not talking about someone that gets 30 tablets of Percocet because they had a toothache and then keeps the other 28, and they end up at some high school party. And we're not talking about people that get into that just take a pain medicine because they just pull their back and they should be back to work. We're not talking about street drugs, etc. We're talking about people with real disease and real pain, and these are what these medications were designed for, and we're really good at controlling pain. So, first of all, again, you have to communicate the pains you're having, and doctors do want to know these things. Secondly, the physicians need to be aware that there are various things they may do to treat pain. I mean, obviously, if you have a broken arm, you don't just take pain medicines. We do something about it. If you have an acute infection, we drain it or we fix it. And we try to prevent the pain, and then try to treat the causes. That's very, very important. But in situations that you're having pain, either because of a treatment like a surgery, because of the disease itself, because of other complications that have occurred, it's really critical that pain be controlled, and you have to communicate to your doctors of what's going on. We have not a large number of non-narcotic pain medications. Obviously, we have anti-inflammatories, and we have the acetaminophen, the Tylenols of this world. We have all sorts of nerve blocks that are going on, and we do have a large number of very effective narcotic pain medications. Used appropriately for pain, narcotics are not, have a very low addictive potential. Because, when you start taking a narcotic to help you get through a test and sleep at night, there's a risk of dependency. But when you're taking a narcotic for a particular pain, the risk of addiction or dependence is very, very small. And so these drugs can be used safely in there. If you look at every single prescription narcotics, it says, may affect breathing. Yeah, if you take a gigantic number of them, it can cause a suppression of breathing, but taking a few of them is not going to cause breathing issues. People don't take their pain medicines, narcotics, because they believe that it's going to stop working. That's not true. These medicines continue to work. They're effective medicines, and in the worst part of the circumstance, you may have to adjust the dose. But these medicines keep working. All these medicines, Tylenol with codeine, all up to morphine, methadone, they're all constipating. They're all constipating, period. They all are. So as soon as you start a pain medicine, you have to be aware that you may need to take something for your bowels. And by the way, your physician should be advising you on that. It's critical along that line to saying to the doctor what pain medicines are working, what pain medicines are not working, what side effects are occurring with the pain medicine. Is it making you oversleepy? You can adjust the medicine, you can adjust the dose. Is it making you constipated? You can adjust the bowels. But these are medicines which are highly effective, and the point of that is by controlling pain, it lets you get back to your life. It lets you be around people and to function, and then there's a greater chance of healing. But pain itself is a really bad thing, and we have to be really careful, in handling that pain. Another problem we see commonly, of course, with cancer therapy, and I will call it a side effect. I guess it's a side effect, but it strikes me as an obvious effect. Is that this is really hard. This is a really hard part of someone's life. Suddenly you're dealing with a disease that is really threatening. Your life is often on the line. The treatments are not easy. The treatments are complicated. You're trying to make tough decisions at a time you don't feel well in what you feel has to be a relatively short period of time because you feel threatened. And then people start doing things to you which make you feel, at best fatigued and maybe other times, awful. And this is a depressing period of life. This is a life where there's many changes that are occurring. There's a lot of losses. Even if I have to take a leave from work, that's a loss, which takes you out of the mainstream, which is a loss. I'm not the caregiver I was. I'm not the lover I was. I'm not involved in the community in the way of the words. I'm not sure what the future holds. Yes?
For me, when I received chemo, it made me very out of it. Like everybody else had to be, I was a burden on society. Right? Everybody had to do things for me.
So the question is that you felt as if you were a burden, or you were a burden and that was hard?
I was uncognitive of what was going on around me.
Okay, so the statement is that you were just so wiped out that you really were you became dependent.
Right.
You were dependent. So there's two types of dependency, as two kinds of sides in my mind. Many sides, but simply put. So there is the perception that one has become dependent on others. And that's a burden on them. And then there's the reality that sometimes that we often really need other people. We really do. We really do need other people. The place I usually start with this is that we reap what we sow. If we spend our lives taking care of others, and we have families, and we've been there for them, when times are hard, and some of that's just raising children, and some of it's being with people. That is a love and a goodwill we build into others, so when the time comes, they're there for us. So, and this has to do with the perception that I'm a burden, and therefore I don't want to go through this, and because I'm going to be a burden on other people.
It also was a thing of depression.
Absolutely.
Definitely, because it's a repetitive depression, because now I have bipolar.
Okay. So
So
it set off a natural depression. So your natural depressive tendencies.
And now I'm bipolar.
Yep.
I had depression to begin with when I had the cancer. And now I have bipolar 7 years later.
Mm-hmm.
So it came back again, the depression, but in a different kind of form.
Mm-hmm. Well, and you're making the points are right that the treatment does add to whatever emotional base you already had, and that's also the really important point that even when you finish being treated for cancer, even when you get beyond it, you're not really not beyond it, right?
You don't always notice it's happening, and then it just gets at you at the last moment.
Mm-hmm. Yeah, it undermines. Well, that's an important point. That is that there's also the treatment you're getting right now, and its effect on you now, and it's your dependency on other people now, and then there's the fact that when you finish therapy, then it's just the problem of getting on with the rest of your life, which is not easy. It's not easy. I mean, the most common way we see this, as we're talking about the colon cancer patient that has the surgery and the chemotherapy and then they're done. And then we see that in breast cancer patients. They have the biopsy and the surgery, the radiation, the chemo, and then they're done. But they're not really done. because something has changed in your head, something has changed in your life, and then you have to just get back to the rest of your life, and that's hard. And that's hard. And if you add to it, your comment about being dependent on others, which frequently you may be during that time, that's another thing that drains you down and makes you feel as if you're less independent. The thing about this emotionally challenging part of your life is, first of all, you have to recognize it. It's natural. I was going to use the word healthy, but it hardly feels healthy, but it's natural. A sane, normal person going through this kind of a difficult time in life, will experience, a lot of emotional complexity. So first of all, it's to say to yourself, you're not crazy. This is just a really, hard time of life, and to give yourself that room. Secondly is the important need, again, your caregivers need to know about, and your caregivers also your family needs to know about it. And it's important as much as possible that the family try to stay in the same place and move through this. So it's important to say to your family, listen, I really don't feel like going out tonight because I really feel, depressed or upset or anxious, etc. I want to stay home. We want to communicate that and share with our family. This is a tremendous, at various points in this path, there is a role for support groups, which can be very helpful individuals. There is a role for individual counseling and individual support, which can be very helpful. There is a role, for antidepressants and medications for anxiety, etc., which can be very helpful for individuals. But it's again realize that this is a really hard time, and then remembering that there is this dysfunction and disjunction in families, because families aren't always in the same place, and that can even make this worse. So it's again recognizing that this is one of the complications of going through this time of your life. It is a hard part of life. It's a life that there are lessons to be learned about yourself, which may be good, and about people that love you that may be good, and about your meaning of life that may be good. But on the other hand, no one would choose this path as a place to getting those kind of lessons. It is really a tough time, that we all have to go through, and we all go through this path individually. And in our own special way. Ellen.
I also want to add to what you said about the value of counseling and support groups for the caregivers as well.
Oh, that's a really good point.
And the children.
That's a really good point.
Because our focus, most of this conversation is about the patients.
The comment is about the importance of involving families and caregivers and stuff in support and in counseling. This is a team sport. All right, there's every single person in the family, down to the 6-month-old baby, is involved in this process, in some way, and the communication is really critically important. I don't know how often I get the following experience. So I go to the hospital and I go in the room, and there's the patient. He's sitting in the bed by himself, and he goes, I know I got the cancer, and this is pretty bad, but whatever you do, don't tell my wife. She couldn't handle it. No problem. So then I walk out in the hall like this, and who's there? His wife. And his wife she says, I know he's got the cancer like this, but whatever you do, don't tell him he couldn't handle it. So then I have no idea what to do. The point being is that these two people have had a life together, and they've shared family and career and dreams and hopes and et cetera. And suddenly there's this disjunction. What I do, by the way, is the solution is I say to the wife, listen, I think he really knows about this, et cetera. I think he really needs to know. So why don't you come in the room and let's talk about it together? Which goes back to my statement earlier, when I see 11 people in the room, I'm really happy because they're all going to hear the same story and we're all going to get to the same place. And that really gets to your point, about that everybody needs to be involved. And there are support groups, for families, and there are support for caregivers, and then we all have to move through through this together. Yeah. So the question is asked about a nasty chemical that your husband had to drink as far as some sort of test.
It goes through all your body, and then they do the test at that center, where they do the blood test, the LabCorp. And they check, he doesn't let me go anymore because I can't stand everybody. But they look at where that dye goes down to make sure it hasn't spread to this, it hasn't spread to that, it hasn't, you know.
So I'm going to broaden out your question a little bit, because I'm not quite sure which test is. I'm not sure which one, but I'm going to broaden it a different way. So the question was asked, is there an alternative to a particular nasty test that your husband has to go through, to monitor his disease? So I'm going to broaden out the answer in this way. Yeah, we're doctors. We love to do tests. I guess, we get up in the morning. My dog's had 4 PET scans. So we love to do tests. But the answer is that almost all of our tests we have a choice for. That's the way I'm going to put this. So I'm not quite sure which test this was, but almost we have an alternative, because some patients, MRIs, 27% of people can't stand an MRI because boom, 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 boom. There's this gigantic sound in this little space. So, okay, maybe we don't do an MRI, or maybe we don't do it as often, or maybe we do a CT scan, maybe do a CT scan. People, other people, throw up when they have upper GIs, et cetera, like this. Well, maybe an endoscopy, maybe a CT, maybe an MRI, maybe some sort of nuclear scan. We do have a lot of choices as far as tests, and also we have choices in the way tests are done. I'm a big fan of colonoscopies. That does not make me happy, on my patients, because the prep of colonoscopy is terrible. But there are multiple different actually preps for colonoscopies, talk about. My point I'm making is this. Right, so we have lots of tests with various nasty sort of things you have to go through. But if there's a particular nasty problem, again, let the caregiver know. The most common response, by the way, is that if I tell someone to have a test that's particularly nasty, they don't want to do it. They say, "Thank you, Dr. Saltz. I really appreciate Dr. Saltz." And then and 6 months later, they're back. I go, "How's the test go?" And they, "What? You never gave me a prescription." That's the I get ignored. I get ignored at the office too. So the answer is look for choices. I'm not sure which test that particular one was, but look for choices.
You have to take soda with it.
Yeah, drink soda for it. Yeah, I think I know what we're talking about, but et cetera. So doctors usually don't recommend soda, so it had to be a particular.
And they said, no, you can't drink diet soda with it. You have to drink regular soda. What do you mean you have to drink regular? Because apparently, otherwise, he wouldn't be able to get it down. That's how disgusting.
It couldn't be diet soda. That's a very interesting test. I'm not quite sure what it is. This is a test that actually is put out by the Coca-Cola Company. Your husband's been going. He's been going to the bar. I just want to. When you don't show up, he's going to the bar. I just want to tell you that. That's we had met before we started. We were talking a little earlier about nutrition. And I don't want us to go further about talking about nutrition. So nutrition is incredibly critical, for getting through this kind of therapy. So first of all, we did mention fluids and hydration. And truthfully, as an oncologist, if for a couple days after treatment you don't eat, I truly don't care. But I really care if you don't drink fluids, because you got to flush the stuff out of your system. That's what puts you back in my office having fainted in your kitchen 2 days later. So fluids are the first level of nutrition that is really critically and vital, and very commonly, like I said, after treatment you don't feel much you're drinking. By the way, there's a real simple solution to that. If you can't drink enough fluids, you call the doctor up and say, "I can't drink enough fluids." And we have patients that come in every day, and we plug them back in an IV, and they watch TV for an hour and a half, and they're all fluid and built up, and they go home. And we do this every single day. And if your oncologist can give you chemotherapy, then your oncologist can do that. And it's really easy it's completely boring. So if you're having trouble with fluids, let them know, because if you give some fluids, it's like stepping up over the hill. So fluids is the most is critical. But general nutrition is very important too. So I'm a big fan of the idea of your body knows what it needs. I mean, people have been successfully eating for hundreds of millions of years. And if you're getting treatment or you have an illness and something doesn't suddenly taste good, like many oncology patients will tell you that they love coffee but they don't anymore, they don't like chocolate, and red meat tastes like metal, then that doesn't mean you should eat those things. It means your body is saying, don't eat those things. On the other hand, if there are certain things that taste particularly good to you, it probably means that your body is craving those things and trying to rebuild. I appreciate the concepts of drastically changing your diet so that it has no sugar, it's full of grain, it's macrobiotic, it's vegetarian, and I understand that opportunity to gain control of your life. But if you do too many sudden, drastic changes in your nutrition at that moment in time, you're just going to stop eating. You know, so I mean, and frankly, the most common way this happens, by the way, is that we have a 75-year-old man or woman, she's got a new disease, and the 23-year-old, reads some nutrition thing, and suddenly they're living, only on alfalfa, and we're trying to understand why the blood tests make no sense at all, like this, why she's losing weight like a rock. You want a balanced diet. Now, we're talking about in the short term on oncology, and in the long term, I think the same advice holds. You want red meat 3 times a week or less. If you eat red meat, if you don't, fine. Fish is really good for you. Chicken is really good for you. Fruits and vegetables are really good for you. And again, people will say, don't eat raw stuff so you're getting infection. It's extremely uncommon. I really much prefer that you eat the things that taste good to you, et cetera. And if you want to do smoothies and if you want to juice, I mean, those are, are really good things. The better you can balance out your natural diet, the better you're going to be to get through this. Now, this is an interesting fact. 50% of patients getting chemotherapy gain weight because our anti-nausea medicines are a little bit appetite stimulants. It's because our metabolism is a little bit slower. 25% lose, 25% stay about the same. So, but that doesn't mean it's necessarily balanced weight. So you want to make sure you're getting protein, you're getting vegetables. You want to get a nice balance. All right. So the following is my bias, and I recognize the people that will fervently disagree with what I'm about to say, but I think the literature increasingly supports this more and more. As a general rule, pharmaceutical, artificial vitamins are at best worthless and may often be bad for you. So your body expects to see micronutrients and vitamins in a certain form. That form is an apple. That form is a banana. Yeah.
Tell me what artificial vitamins means.
So I would say anything you take in a pill that's supposed to be vitamins. So I'm talking multivitamins, okay. Vitamin C, vitamin D, vitamin B. Well, not D, D's artificial, but there may be data for it. We'll get back to that. Because your body expects to see these things in a certain form. A piece of fruit, a piece of broccoli. That's the form.
He's not a rabbit. How can you do it when the man doesn't eat salad?
Well, has he survived right in his life up to now?
Yeah.
Okay, he's probably.
I know darn well he's not eating just what I pack.
So, to answer your question, so the question is asked, what if someone doesn't eat at all? So the use, in my mind, of he doesn't eat carrots, which are of questionable benefit anyway. So the point is that multivitamins are probably at least useless, and there's increasing data are probably bad for you. Look at the European antioxidant stuff in lung cancer. They increase the risk of lung cancer. Look at the Women's Health Study. Women that took multivitamins were more likely to die. You look at the Kaiser assimilation of their data out of Oregon. So the use of multivitamins, vitamin C, vitamin D, antioxidants, particularly in pill form and not in the form of an apple or an orange, are probably at least useless and bad for you. And there's a fair amount of data may inactivate, and certain probably clearly do activate, certain chemotherapy, certain cancer therapies. Now, if someone has a nutritional problem, so we've identified that they have low B12, we've identified that they're vitamin D deficient. I mean, that's a medical issue, and it needs to be supported. But when we're talking about nutrition and the patient getting active therapy for cancer, those things probably have very little role. A balanced nutrition otherwise is important. Now, other things interfere with eating other than just picking what you want and what tastes good. Mouth sores can interfere with eating. Diarrhea, abdominal pain, various devices like colostomies or things, etc., can interfere with eating. And that's the kind of situation that you want your oncologist to be aware of. That's the situation where it may be very valuable, to a comment that was made earlier about seeing a nutritionist in consultation. That's to be where then a gastroenterologist may need to be involved just to deal with problems with maybe chronic diarrhea, chronic abdominal pain and cramps, etc. I mean, this is not something to just kind of leave to the side. This is a core part of treatment because you can't heal a wound, if you have no protein in your system. and you're not going to be strong unless you have, calories that are pumping through, and you're not going to rebuild. So it is extreme. And your bone marrow is not going to re-heal from chemotherapy, unless it has these nutrition. So nutrition is really critically important. It has to be there, and it is something you should be discussing. And if you are using vitamins or truly complementary medical things, whether that's something that you're taking, whether that's Reiki, whether that's yoga, etc., let the clinicians know about it. There's very strong evidence for the use of acupuncture as part of supporting cancer therapy, anti-nausea, energy, pain, etc. But let your clinicians know about it. Because then they'll want to work with you, and they'll plus also want to know how it might interact with ongoing therapies. And most oncologists are very comfortable, with the idea, of getting, other sorts of supports, during treatment, et cetera. Chiropractic, or other sorts of things that maybe support you at the time. But let them know what's going on, so they can put that in, into the general, treatment plan, and they know, what to expect, particularly as they're interpreting the tests and treatments, that happen as you go through this.
How do you support B12 deficiency?
So the question is, how do you support B12 deficiency? So B12 deficiency is a defined medical condition. B12 is a vitamin that has to do with nerve function and bone marrow function. And when B12 levels get low, really bad things happen. It's not a little bit of energy. It's you get your B12 low enough, you can't move your legs anymore, and you go blind. So it's not like minor. So B12 deficiency can be supported, is identified by a blood test, and it's supported either by injections of B12, or many patients, if you take a high enough dose of an oral B12, that will be enough to get their levels up and support it. But either way, you have to track it, track it by blood test. A lot of people think that there's a common misbelief, because there's no evidence support at all. B12 shot that we should all get one, it's just good for energy. It's a water-soluble volume, and you pee it out the next time you're in the pot, so you just wasted a needle shot in the arm. So if you're not deficient, you're not deficient. Deficient. So B12 deficiency is a true disease.
Okay.
Hey.
About flaxseed, I don't, these things I've never heard of before, but all of a sudden I'm giving them memories. I'm taking it too, I've got problems too.
Flaxseed is actually a really good nutritional support. It's a really good support. A lot of people put it in smoothies, they put it in other foods, etc. Flaxseed C is very popular now because it's a little more palatable. So that's you're right. That's.
Oatmeal, I throw it in rice because he doesn't know what's in it.
You're sneaking the flaxseed into the rice. That's good. That's that.
Also, like, they claim, I don't know, my kitchen table looks like some of the herbs and spice racks. I got garlic, I got onion, I got, you name it, we got it.
Well, what's interesting about what you just say? So what do you just say? But that's an interesting point. You have garlic, and you have rosemary, and all these different spices, etc. These are all foods. So when you're, if in the sense that so their body expects to see them in a balance, so they all probably do have a role. It's when we take it, to make it, too artificial that we really get into problems.
Determined type thing, but now they said somewhere there was a warning: don't take it as a pill because he has high blood pressure that can affect him. He had kidney stones. He had kidney stones. This can form kidney stones. This can form. I'm dizzy already.
It sounds like you're right on top of it. Actually, I'm kind of impressed.
5 books at home, sitting there. I'm listening to the radio shows, listening to everything.
So there are other side effects that that commonly occur with cancer care that tend to be more specific for particular cancers. So you have shortness of breath, which is a common problem for which we have actually really good therapy. There are some disease, there are problems if you have cancers or some sort of injury that's occurred to your head. So problems with walking or problems with speech, that can, again, things that we know more and more about. There are side effects for most organs of the body. In certain situations, can have side effects for which we have really good ways of preventing and monitoring. So a lot of the tests that your doctors are doing, the questionnaires, have to do with preventing those long-term side effects. But the goal of all of this, the goal of fighting the side effects is to allow you to have the greatest chance to continue with your life. the greatest chance to, to fight the disease, the greatest chance to be cured of the disease, the greatest chance to be involved, in society, and by staying ahead of this, being aware of this, the chance that you're going to have, serious problems, the chance that you're going, is made that much less. The chance that you can heal from this mentally and physically is that much more, and you're going to be that much more in control of your life, and the opportunity, to move forward.
For me, I feel a lot, but I still can't drive that far, basically. My sister lives in Burlington, I don't see her that often. And also, I didn't know it was coming on. I just had a common cold, and it developed into depression for me.
It did.
So, yeah.
But at this point, so you're coming to say it's even years later, some of these side effects kind of catch up with you, and you don't even know what's going on.
June of 2014, I got diagnosed with bipolar depression. And before that, people knew what was going on outside of me. Like the kid I work with, he's multiply handicapped. And he said he noticed it in April. I didn't notice it until June.
Right.
That's why before I went to the hospital in June.
Right. Which is unfortunately common when that's again one of the reasons it's so important to keep connections, because a lot of times, particularly with depression, those kind of things, they catch up on us before we even know it's there.
Right.
And other people notice it. Yeah.
Tell me, what's the story with heredity?
With hereditary.
My husband, yeah.
Okay.
My father had, like the size of a golf ball in his, lost the voice box. My mother-in-law had a mastectomy. For her, it worked out in that they did the radical, and she lived for many years. It was amazing. She was a cancer survivor from many, many years ago. I guess she was, but he didn't. He went
So,
through a lot of chemo
so your question is a question about hereditary and cancer.
I'm worried about. My husband has, I won't, because I can't, I'm old, and women didn't talk about, it wasn't that one, it was in that area. So, I told him.
So your question is about hereditary cancer. All right. So this is a.
Because of that, am I going to have to worry that he's going to get it in the throat? Is he going to get, like what, he wouldn't get the mastectomy, he wouldn't get it, because.
So given the fact, so heredity and genetics in cancer, which is, which is clearly something we could talk about for the next month. But I'll boil it down to the most basic concept of what is cancer, which is really the best answer to your question. So, right, where does it come from? What is cancer? So all cancers are the same thing. Every cancer. So we all stop growing at some point in our life. When we're infants or into fetuses, and we grow very quickly. But when we get into our teens, we spring up and then we stop growing. If we're injured, our wounds heal, and but that's growing, and then it stops. Growth in our bodies is extremely closely controlled. It's critical for every living thing that growth stops or starts when it's supposed to. And so growth, is a vital system in our body. All growth in our body is controlled by switches in every cell which control growth, and they're genes, genetic switches in every cell, and they are on-off switches that turn on to grow or off to grow when we're not supposed to. All cancers occur when these growth control switches, these genes, are damaged. Sometimes they're supposed to be off and they get turned on. Sometimes they're supposed to be on and they get turned off. But that is every single kind of cancer is caused because of damage to growth control genes. So how do growth control genes get damaged? Well, this is just like a wall switch that you would buy at the hardware store. You can walk in the store and you can buy a bad switch. All right? And people may be born with bad switches. And we call this hereditary cancer. So we're talking about genetically inherited cancers that can run through families. So you can be born with a bad switch.
They smoke.
Well, that's the second thing that happened.
But we don't. We ate too much. But we didn't, the drugs we took, we did take.
So it's first.
But the drugs we took were prescription antibiotics, all the stuff but we ate too much. And sugar, obviously.
Well, that's the point. Okay, so the first thing is the switch can be bad. The first switch can be bad. The second thing is that you can buy a switch at the hardware store, which is perfectly good, and you can drop it on the way home. You can break the switch. So when you think about smoking, eating too much in sugar, living in certain states of the United States, which have high amounts of chemicals and chemical in the water, radon in our homes, radiation exposures, anything that can damage the switch. So that's the second thing. So you get born with a bad switch, or you damage the switch. And the third thing is, frankly, the switch can get old. And you turn the switch off enough times, et cetera, and the switch just gets injured and stuff, and the switch malfunctions. And the reality is cancer does increase as we get older because these switches get damaged. We believe that most cancers are all the above. So you're born with a switch that's kind of a crummy, and then you get exposed to a little bit of a chemical or radiation or something, and then we all get a little bit older, and then we get cancers. And this has been referred to as a multi-hit hypothesis, and that is one switch is damaged by this, one switch is damaged by this, and the switch, and then the cell starts to grow. So that is all cancers. Most cancers have a major environmental component. Clearly the rates of cancers on a global basis have increased in Western civilization just as a matter of living longer, et cetera, and we're exposed to, et cetera, but they're environmental. But there's also major hereditary components. So some cancers do run through families. Some cancers just occur because everybody smoked, and there's a lot of cancers in all the above. What's exciting about this observation, which kind of mind-blowing about this observation, is that we really know more and more the individual genetic switches of every single cancer. More and more we're learning which switches are damaged. So you take Gleevec, which means that you have a particular mutation in your cancer cell known as BCR-ABL, or the 922 translocation. The drug you take, Gleevec, also called imatinib, specifically targets that gene. That's how it works. It goes specifically after that gene product because most of the diseases that you use to treat Gleevec, CML, and GIST tumors have that mutation. That's the mutation that caused them to grow. So that drug specifically targets that. More and more we're identifying these genes in more and more diseases. So we know more, we talk about BRCA and breast cancer. Well, those are growth control genes, and we're learning more about that. But when we know about the gene, we can start to turn them off. We can also use it to identify cancers by finding trace amounts of those genes. And you talk about testing stool now for the colon cancer gene in the stool, not just blood, but the stool. You're talking about doing blood tests, looking for these gene traces, et cetera. And then we can start to target. Now, some of this gives you an idea how hard cancer can be. While we haven't cured it this week, as quickly, because CML is caused by this one gene, also called the Philadelphia chromosome. It's caused by this one gene. So every CML patient basically has that one gene that's it is. But if you do a genetic test of a lung cancer patient, of a lung tumor, you may find 100, 200, 300 damaged growth genes in that one lung cancer. So it's really hard to imagine how you can have this person take 300 pills. So that shows how hard this is. But now that we understand this and we've identified this gene, etc., more and more we're going to be able to not only detect this disease, prevent these diseases, but we're going to be able to target these genetic variations.
So that's helpful to have a sense of the direction we're going in, but for someone like this woman who has a multitude of people with cancer in her family, what would be the best advice for her in terms of sort of having a conversation about, are they connected?
Right. So, there are some cancers, right. So it would be important, so the question is, in an individual family, what's the proper approach for genetic screening?
My son has one child, I have one grandchild. He died of a second. I'm not quite sure. They've never admitted it, and I guess, but his wife's mother had breast cancer. My mother went with lung cancer. My father, both his, he was like, you're doomed.
So Myrna, let's
So-
let Dr. Sal respond.
So the answer to the question is, I would start by going to my primary doctor, and if your husband is an oncologist, I would start by going to the oncologist and saying, what do you think of this pattern? And I would write it down. Real good use for lists, because then you walk out and you go, Aunt Myrtle had ovarian cancer. I forgot to tell him, which would be really important. So I would write it down beforehand, I guess, and I would go to the primary physician, if that's the person seeing, and I would already go to the oncologist and say, what do you think of this pattern? Now, some patterns are just obvious. This was caused by, where you live, this person, it might be. But on the other hand, the oncologist will also say, I understand this lung cancer over here and maybe this mouth cancer over here, but you've got an ovarian cancer over here, occurring in a 48-year-old. That's a genetic disease some of the time. And the oncologist at that point then would often recommend, or the primary doctor, that in that case, that if they think that this doesn't fit, this could fit maybe a genetic pattern, that you see a genetic counselor, which are a number of genetic counselors, which is an expanding specialty, which is really critically important. It's just going to grow, et cetera. Or sometimes oncologists themselves would make a recommendation as far as testing. But I would start by reaching out to the primary doctor, or the oncologist, if there's one available, who will at least be able to say, yeah, that fits into a genetic pattern, that requires evaluation. The thing about if you can find genetic patterns in a family, that can be done it can be good for family planning sometimes. But most importantly, it can tell you the best way to screen, and watch and observe, family. So if you have a family that has a genetic tendency towards early colon cancer, maybe they don't get their first colonoscopy when they're 50, maybe they get their first colonoscopy when they're 25. Maybe they don't get their first mammogram now, with the ACS 45-year recommendation. Maybe that's a person that gets it with the first mammogram when they're 35, or gets breast examinations, twice a year starting at age 20, depending on the situation. So genetic information can be very powerful. I run all the time into families and patients, or people who are loved patients are saying, I don't want to do the testing. And I don't want to find out because I just really want to know. And I appreciate that. And there's two concerns about people not wanting to knowing. One, people worry that somehow it's going to affect whether they get insurance or they can get jobs. The federal law prohibits that. It's a brilliant law written more than 2000, I think, which says you can't prorate insurance or based on genetic information. So that shouldn't be an issue. But the more concerned people people are scared and they just don't really want to know. My thought is that I reverse that. This is a weapon. You can use this to protect yourself, your family, your children, and therefore the more information you know in this area, the better, you protect yourself. My analogy is, I look when I cross the street every single time. I know still not look occasionally because I want to know that the car's coming or not. So the same thing here. If you have more information, if you're able to design, a treatment plan or a protection plan or a product plan, which can keep you and your family healthy. And the reverse is also true. Now, if you don't have a gene, what a great gift to give to your family, to give to your children. No, I'm sorry, that my mother, did have this cancer, but I've checked and I don't have anything to this cancer. There's no reason you have to worry about it. Well, can there be a better gift than that? So they don't have to worry. And then many of these genes, aren't carried down to every person. They're carried to some people, so people know what to test for. This is really valuable, very information. We're moving soon to an era when people will be broad gene screening panels. They won't be specific anymore. Everybody will basically get some sort of genetic panel to screen for all cancers. We're not far from that. We're not there. Everybody shouldn't run out and get genetic testing yet. Clearly we don't know what to do with most of the information yet or how to design it. But we're moving into that kind of era that we have more and more information. It's less and less expensive. Breast cancer genetic testing 3 years ago was $4,000. Now the base testing is $300. This stuff's getting less expensive and more powerful. So this is again a way of protecting your family as they move forward.
Does anyone else have questions about what Dr. Salwitz covered or other topics relating to cancer treatment and side effects? This was an important topic, so I'm glad that you brought that up.
No, I appreciate it. You like one, and you should do a radio show too, and a TV show.
The problem is I can't dance. The problem is I can't dance. Huh? So
he doesn't dance, and you.
So thank you very much for being here today. I guess, and if questions, please thank us, sir.